Good afternoon, Dr. Kumar.
Hi, hello.
How are you? You have a minute?
Of course, sure, of course, yes.
The urologist team called me regarding Mr. Nasif, who he is a 20 years old man who underwent orchiectomy 2 weeks ago, and the biopsy showed nonseminoma. The CT imaging showed a 5 centimeter mass in the retroperitoneum, and the urology team wondering if we are going to offer him any adjuvant chemotherapy.
Sure. So do you have tumor markers?
Indeed. The alpha fetoprotein is 900 and the beta HCG is 3000. Okay, that's great. I will get back to them with the chemo plan and I will update them.
Marvelous, thank you. All right.
Oh, wait. Can I ask you one more question, please?
Oh, sure.
Yeah.
Is it about the same patient or
Yes,
someone else?
yes, same. The urology fellow asked me if there is any value of or any benefit of referring this patient to the genetic counselor. But I'm not sure if there is any genetic abnormalities linked to the germ cell tumor.
As lymph node nodes mass is between 2 and 5 centimeter, this is an N2 disease. Hence, the overall stage is 2B. AFP less than 1000 and BHCG less than 5000 is an S1. This does not upstage him though. He has got good risk disease, and either EP times 4 cycles or PIP times 3 cycles would be acceptable therapeutic options adjuvantly for him. Compared to adult solid tumors such as lung, kidney and bladder that have mutations rate between 8 and 11 mutations per megabase, the mutation frequency of testicular cancers is much lower, at approximately for half mutations per megabase. The only consistent chromosomal abnormality of testicular cancer is the presence of an isochromosome of chromosome 12. This chromosome abnormality can be used not only as a diagnostic molecular marker for seminomas and nonseminomas, but also as part of the workup for cancers of unknown primary. Other chromosomal abnormalities associated with testicular cancers have also been reported, such as an increase in the copy numbers of chromosomes 7, 8, 17 and X, as well as a decrease in the copy numbers of chromosomes 4, 11, 13 and 18.
Mr. Abbas, welcome to the clinic. I actually received the result of your recent blood test, and the beta HCG and the LDH both are normal. However, the alpha fetoprotein is raised at 9,000.
9,000?
Yeah.
That's very high. But is it going to change our plan?
Well, as you know, the surgery was done just about 4 weeks ago, and it was an early stage 1 disease, and the recent CT scan did not show any evidence of the disease elsewhere. Non-seminoma cancers can have persistently high markers level, and I would still suggest a treatment.
Patients with stage 1S nonseminoma exhibit persistent elevation of serum tumor markers post-orchiectomy with no radiographic evidence of disease. Stage 1S is defined by any T, N0, M0 and S1 to 3. The treatment for stage 1S nonseminoma is either PIP times 3 cycles or EP times 4 cycles.
Dr. Becker, may I ask you about Mr. Akram, who is next door with me?
Sure, of course, go ahead.
Well, he's a 25-year-old who underwent orchiectomy 8 years ago for stage 1A testicular seminoma that did not require adjuvant treatment. And his tumor markers, the beta HCG and LDH, were never elevated. The blood from 3 weeks ago showed the beta HCG is slightly elevated at 15.
Yeah, I think I remember this patient. Didn't we decide to scan him?
Yes, actually the CT scan was done and it's normal.
So what do you think is going on here, Nabil?
That's the question was.
A persistently elevated beta-HCG during and upon completion of treatment for metastatic testicular cancer signifies an incomplete response to chemotherapy and is associated with a very poor outcome. However, a false elevation of beta-HCG have also been reported and should be considered in the differential diagnosis. Marijuana use and abnormal renal function have been reported to cause false positive elevation of beta-HCG. Another frequent non-malignant cause of a persistent false elevation of beta-HCG is hypogonadism. In addition to those, another potential cause for the false positive beta-HCG test is the presence of IgG immunoglobulins in the serum that mimic immune reactivity, termed heterophilic antibodies. These antibodies cause false positive by forming a bridge between the capture antibody and the labeled antibody used in the immunoassay, thus mimicking the role of beta-HCG.
So can we discuss Mr. Mohsin now, please? He is a 28-year-old patient with a right testicular mass for which we did a biopsy that confirmed a pure seminoma. We did also a CT scan, which we are discussing today.
Yes, sure. So the CT scan shows the right testicular tumor invades the scrotum with lymphovascular invasion. It also shows liver masses suspicious of metastases. Interestingly, the erythropoietin lymph nodes are all negative and no other signs of metastasis elsewhere.
Well, yes, in fact, we did a biopsy from one of the liver lesions and the result came back to be a testicular seminoma. Tumor markers are all negative and the patient is well and fit with no comorbidities. I wonder now what our oncology colleagues suggesting.
This is a T4 node disease. As he has a non-pulmonary metastasis, the M staging is 1B. The M1B stage would signify a poor risk for nonseminoma. However, for seminoma, this would signify an intermediate risk as seminomas do not have a poor risk groups. In this patient, the overall staging is 3C and the treatment for other stages 2C to 3 seminomas are for good risk AP times 4 cycles or PIP times 3 cycles, and for intermediate risk PIP times 4 cycles or VIP times 4 cycles.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share and subscribe, and don't forget to join us every Thursday 5 p.m. Greenwich time.